In this module, I'm going to discuss ventilation perfusion mismatch, or VQ mismatch. Ventilation is the air that reaches the alveoli, and perfusion is the blood that reaches the alveoli. In an ideal situation, we would have every part of the lung being equally ventilated and perfused in a 1-to-1 ratio, but this doesn't happen because of gravity. Here's one lung. As we move from the apex, or the top of the lung, to the base, or the bottom of the lung, both ventilation and perfusion increase, but perfusion increases more so. So at the apex, there is a high VQ ratio, high, and at the base, there is a smaller V compared to the Q. The Q is a little bit bigger, and so you have a low VQ ratio at the base. Now somebody smart figured out that on average, there is a VQ mismatch for the entire lung. And on average, this ratio is 0.8. And in class, we talked about the alveolar arterial gradient for oxygen. Big A being the alveolar concentration, and little a being the arterial concentration of oxygen. Now we can measure the little a through an arterial blood gas. The big A is really a theoretical concept, since we can't go into the alveolus and measure the concentration of oxygen because that would be very invasive. We calculate the big A based upon several factors, including the inhaled concentration of oxygen. But because of this physiologic VQ mismatch of 0.8 on average in the lung, because of gravity, there is a small physiologic difference in the AA gradient, and this is less than 10 millimeters of mercury for a healthy person. That's how we learned it in class. So one major way to affect gas exchange is to have blood going to an area of the lung that is not as well oxygenated as it should be. The other way to affect gas exchange is through diffusion abnormalities, but I'm not going to go into detail about that in this video. So, there are only two possibilities for someone at rest to have a high AA gradient, or a large difference between the alveolar and the arterial concentration of oxygen. One is VQ mismatch, and the other is shunting, which is basically an extreme version of VQ mismatch. Diffusion abnormalities can also give you a high AA gradient, but that usually takes place during exercise. So to better understand how to find a high AA gradient at rest, I'm going to walk you through 5 scenarios to better explain these abnormalities. In the first scenario, I'm just going to draw a healthy lung unit. So here, the straight parts being the bronchial or bronchi and bronchiole, the airways, and the circular part is the alveolus, or where gas exchange takes place. Now below the alveolus, I'm going to draw the capillary with blood going through. So in a healthy individual with patent airways and clear alveoli, when you breathe in, oxygen comes down through the airways into the alveolus, and ventilation is good. In the healthy individual, blood flows nicely, so perfusion is good. So here we have a normal VQ ratio, healthy person. In the second scenario, we have something clogging up the airways. Here's the lung unit again. And this person has chronic bronchitis. So instead of having clear airways, this person has a lot of secretions that's getting in the way of ventilation. So the secretions I'm going to draw in green. And again, below the alveolus, there's the capillary bringing blood. And this person doesn't have any problem with perfusion, so there's still the same amount of blood going by as before. However, because of these secretions, not enough oxygen is getting down into the alveolus, into the airspace as before. And so here, you have a smaller V than you did before. But the perfusion is normal, so you have a normal size Q. And because you have you have less ventilation and normal perfusion, this is what's known as a low VQ lung unit. And because the blood going by is receiving less oxygen than it once, the arterial concentration of oxygen is lower than in a healthy individual. And there is a larger difference between the alveolar concentration of oxygen and the arterial concentration of oxygen. So this person will have a high AA gradient in the second scenario. In the third scenario, we have a pneumonia. Here's your lung unit again. And here's your capillary going by. Perfusion is normal in this person. Blood's moving fine, nice by the lung unit. However, because of your small pneumonia, you have some fluid filling up the alveolar space, filling up the airspace. So in this individual, you have patent airways, but your air spaces are not clear. So air is getting down the bronchioles, but it's not getting enough oxygen as in a healthy individual into the airspace. And so once again, although the problem is different than in the second scenario, effectively your ventilation is lower than it should be. You're not getting enough oxygen into the air spaces. So you have a small V and a large Q, as in the second scenario, and this again is a low VQ lung unit. So in both of these cases, you will have a high AA gradient because not enough oxygen is diffusing into the arterial blood supply. So there is a higher difference than normal between the alveolar and the arterial concentration of oxygen. Now in the fourth scenario, we have an individual with pulmonary edema. So here's your lung unit, pulmonary edema. Here's your lung unit, and here's your capillary going by, with blood perfusing nicely. However, because of the pulmonary edema, fluid has filled up the airspace. Here's your fluid in green. And unlike the smaller pneumonia that you had in the third case, this fluid is filling up the entire airspace of this lung unit. And if you remember, the only places where gas exchange can occur are in the air spaces. So even though your airways are patent and oxygen is getting down into the airways, it's not getting into the alveolar space, and so therefore gas exchange cannot take place. So in this scenario, you don't have any ventilation. You have a 0 in the top part of that equation. Your perfusion is fine, so you still have your Q, but you have a 0 on top, and so effectively this equals 0. And we call this a 0 VQ lung unit. And another way to call this, another term we use for this, is a shunt. And if you remember in cardiology, a shunt is when blood moves from the right side of the heart to the left side of the heart and never gets oxygenated. There's a hole in the heart or something, and blood moves from the right side to the left side, never goes through the lungs, never has a chance to get oxygenated. So in this case, because of the pulmonary edema, even though blood is getting into the pulmonary capillary bed, because it's not interfacing with ventilation, because it's not interfacing with oxygen, effectively you have another shunt here, just like a cardiac shunt. Blood is moving from the right side of the heart, getting back to the left side, and it's never getting oxygenated. So this will give you a high AA gradient. It's another example of something that will give you a high AA gradient because you have blood going to an area of the lung that is not well ventilated. In this fifth and final scenario, we have a patient with a pulmonary embolism, or PE for short. Again, here's our lung unit, and below the lung unit we have our capillary, going by usually carrying blood. But in this situation, this patient has a massive clot, which I'm going to draw in orange, impeding the flow of blood. So here, because you have patent airways and clear air spaces, ventilation is normal. Ventilation is fine. We have a normal V. But because we have no blood flow, we have no Q, so we have a 0 on the bottom of this equation. Another term for this situation is dead space. Effectively, this pulmonary embolus has created more dead space in the lung because it has created a lung unit with ventilation but no perfusion. Now this situation in itself, isolated, this lung unit, will not actually create a higher AA gradient because, if you remember, in order to create a high AA gradient, you need to have blood flow going to an area of the lung that is not well ventilated. Or you need to have a diffusion abnormality. And this actually is neither of those cases because you don't have blood flow. So, if that's the case, then why is it that a pulmonary embolism can result in a high AA gradient? The answer is not completely understood, but the theory is that the blood clot causes the release of inflammatory mediators, which I'm going to draw here in green. And now these inflammatory mediators can affect nearby areas of the lung. The theory is that these inflammatory mediators can result in surfactant dysfunction and bronchoconstriction. So if you remember in our second scenario above, when you have smaller airways, you don't have enough ventilation taking place. And if you have surfactant dysfunction, because surfactant is what keeps these alveoli nice and open, if the surfactant is not functioning well, the alveoli can collapse. Another word for that is atelectasis. So if the alveoli are collapsing, you're not going to get ventilation taking place, and if your airways are narrowing, you're not going to have as much ventilation as normal, and so you're going to have smaller V's in these nearby areas of the lung. And those areas of the lung, because they don't have pulmonary emboli in them, are going to have normal perfusion. So what this clot has done is it effectively has created low VQ lung units in nearby areas of the lung. And if you remember in scenarios 2 and 3, when you have low VQ, this will result in a high AA gradient, a high difference between the arterial concentration of oxygen and the alveolar concentration of oxygen.